So I think four of you, totally five of us. Sanyo, you decide when to stop. You are the moderator today, so
Yeah,
you
yeah.
let us know when to stop because I
Yes, sir.
cannot decide that. So early stage lung cancer patient. Let's take up the 67-year-old gentleman, non-smoker, cough, chest X-ray and CT scan showing this nice lesion in the left upper lobe, and PET CT shows nothing else. There are some small sub-centimeter prevascular lymph nodes. So we'll start with Aparna, madam.
Yes, sir.
Biopsy is come as adenocarcinoma. So what do you do next when you get such a patient?
I'll ask surgical oncology opinion, sir, for resectability. And parallelly, I'll also do EGFR, ALK and ROS, PDL1, and we'll take a surgical opinion.
Fair enough, I think. Sanyo, what about you?
Yes, sir. Yeah, right. I mean, probably a year before, probably we would have just referred to our surgeons for surgery. But then now, of course, we have to do the EGFR and PDL1 testing.
Yeah, I think the question, Vijit, is would you recommend a brain MRI at baseline for such early stage non-small cell lung cancer?
For early stage, maybe not, sir. I would not do a MRI brain.
Okay, so I will not go into this role of pathological or mediastinal staging because I think we leave it to the surgical oncologist. So MRI brain actually is suggested for somebody with stage 2 and above. Stage 1A, it's not suggested. Stage 1B, it is optional. This is according to the NCCN guidelines. So I think it is fair enough not to do the MRI upfront for a very early stage disease. But if it is becoming stage 2 and above, preferable to do an MRI to make sure you're not missing anything there before undertaking a major surgery. So this patient, they did an endoscopic ultrasound, no enlarged mediastinal lymph node, so hence underwent surgery. This is the report PT2N1M0. Karthik, what would you do next for this patient?
Yeah, if EGFR has not been done previously, now we have tissue, so definitely we'll do a EGFR. I know about EGFR because after Rachan's talk, definitely, I mean, it has made a huge difference. So EGFR is a must. Probably I'll also ask about ALK and PDL1.
Okay. Madam, what about you? What would you do? Would you ask all
Yes,
these
sir.
things?
We'll ask for everything because these patients, even though suppose the patient comes ALK positive, we may not give anything now, but they may progress, and we'll have the baseline investigations in hand.
Yeah,
So
fair enough,
we'll get
Karthik.
everything, sir. Yes, sir.
Okay. So, in your practice, Vijit, what are the chances that patients have early stage lung cancer? And if so, what percentage really undergo surgery?
Sir, so in the last few years, only one or two patients I remember, sir, who have undergone surgery. So that's very, very less. Most of them are stage 3 and above, sir, and they are not fit for surgery. So I would say 10% maybe undergo surgery, less than 10%.
Okay. Sanyo, what about you? High-end patients in UMC?
Yeah. So I think after in last 4 years, if I can remember right, I have seen 4 patients who have underwent surgery. Yeah, 4 patients, and in that I think one patient was out of that 4. The surgeon operated thinking it is very early cancer, but then there are some large mutational nodes when I did the PET scan. So he had not done the PET scan. So otherwise, yes, there were 3 early lung cancer patients whom I have seen operated, and in that 2 were in last 1 year. Yeah. And in that one was EGFR positive.
Okay. Can I ask you what you did for that patient?
He is on osimertinib.
Oh, excellent.
Okay. But then we will discuss that later. Yeah. I'll put that question at the end. In fact, I have one question regarding that case. Yeah.
Okay. So, what shall we do is, okay, this patient came as EGFR positive. Karthik, what would you do next? Would you offer adjuvant chemotherapy?
Sir, osimertinib if the patient can afford, but if the patient cannot afford, maybe I think chemotherapy.
osimertinib, or if osimertinib is not affordable, what would you do?
We are not able to hear you.
Can you hear me now? Can you hear me?
Sir, we are not able to hear you.
Can you hear me now?
I think it is very low volume.
It is now?
Yeah, now it's
Yeah,
audible.
better.
Okay, sorry. So if somebody can afford, I agree, osimertinib. If somebody cannot afford, what would you do, Vijit?
Chemotherapy, sir. Adjuvant chemotherapy.
Okay,
Platinum-based doublet, maybe.
fair enough. So the benefit of adjuvant chemotherapy, I think, is clearly seen with LACE. And when they subdivided it, the maximum benefit was in stage 3. So we want to definitely discuss this trial, the Adora trial. This is a famous trial of 2/3. So you can see that many 60s are there. Age is around 64, race is around 64, females are 64, everything is around 60s. You can see adjuvant chemotherapy also around 60s. Interestingly, 5 patient, I think 5% of them had stage 3 disease, not stage 4. So you can see excellent disease-free survival, which was clearly shown by the previous speaker. And compared to somebody getting gefitinib or erlotinib, this seems to have a significant benefit. So, Karthik, if somebody cannot afford osimertinib, would you use a combination of chemotherapy plus gefitinib, or would you use
Yeah,
chemotherapy first?
actually, I was about to tell this because even though the data, strong data is not there, but the TMH data is there in metastatic setting regarding regarding the platinum-based chemotherapy plus doublet chemo plus gefitinib. Maybe I will put them on gefitinib, sir, along with the platinum-based chemotherapy.
Okay.
Sir,
Sanya,
we
what
had
about
I
you?
such
have
a
one
case.
patient like that. Yeah, I have
Okay.
one patient like that. So who was actually operated, EGFR came positive, and I gave actually 4 cycles of cisplatin based chemotherapy plus gefitinib for 6 months, 1 year.
Fair enough. Dr. Aparna, go ahead.
Yes, we had one patient in Kidwai, sir. He was stage 2, and we gave pemetrexed carboplatin 4 cycles, followed by gefitinib like maintenance. So I think that
How
also
long?
we can do. Instead of combining chemo and gefitinib, we can even give chemotherapy as an induction and then followed by maintenance gefitinib also. We gave for 2 years gefitinib.
Fair enough. Yeah, I think that's a fair enough call. Sanyo, any criticism of this trial?
Which trial, sir? I mean, Adora or?
Yeah, Adora.
Okay. Right now, I cannot remember anything like that which I can criticize at this point of time. Coming to the question, what we just asked, that extrapolation of that TMS study to the adjuvant is a very interesting thing. But then I've never thought that way till now. I mean, whenever I've used only adjuvant. I mean, in those 2 patients, what I said, I had used the adjuvant chemo only. Did not think of adding gefitinib to that. But then it was an interesting thought process.
Okay. Vijit, any thoughts on what would you do for such a patient? Whether you would use a combination of gefitinib plus chemo or sequentially, or any comments on the Adora trial, the negative comments?
I would, sir, to answer your first question, yeah, I would probably give chemo first and probably gefitinib maintenance later on. Depending if the patient is frail, I wouldn't give all together. So if a patient has undergone surgery, would be obviously fit, but I would probably add gefitinib as a maintenance rather than combining together with the platinum-based doublet. I agree with Dr. Karthik that we have a strong data in the stage 4 setting, but in stage 3, I'm not sure if I'll be combining it, sir. And criticism, I can't think of one right now, sir, about Adora.
Okay. So I will just bring out one or two criticism of this trial. you can see that brain imaging MRI was done in around 50% of these patients. So is it possible that CT scan, we know is not an optimal agent. It can miss at least 10% of brain metastasis. Is it possible that, osimertinib here was used for metastatic setting rather than for patient as an adjuvant setting? That is one. Second thing is we already knew this DFS benefit with even first generation TKIs. So, it's like gambling. One of the comments was this is a gambler's dream. So, you already know you're going to win it. You know that DFS benefit is going to be there. It's just a matter of how much money you're going to make. It's just a gambler's dream. So that is the other, thought process. So Dr. Aparna, your thoughts on that?
No, sir. I didn't understand how this. How it's gambling. I couldn't understand.
See, I didn't mean like gambling. What I
I mean,
meant was this.
Whatever. Yeah.
Yeah, we already knew that there is a significant DFS benefit when you use gefitinib and erlotinib.
Yes, sir.
So if you use a third generation TKI against placebo, would it not mean that anyway patients are going to benefit? So we already
Yes.
knew that results
Okay,
are
the
going to
class
be there.
effect was already known. Okay,
Yes.
sir. Yeah.
That is one thing.
Okay.
Second thing is the MRI was not mandatory. Is it possible that it would have been an adjuvant treatment?
They would have done it later, sir. I think they would have done it later. After surgery is over, they would have done MRI, because if they do it before surgery, they wouldn't have done surgery only, no, sir. Maybe they did it later, before randomization or something like that.
Okay. Vijit,
I don't
your
know.
thoughts on
We'll
that?
check it, sir.
Yeah. Vijit, your thoughts on that?
Sir, I think there are like very early stages. Like stage 1, like you said, we don't have to image the brain upfront. So, I mean, that is kind of fair, no, sir? I mean, like in stage 2 and above, I think we need to, because that's what we are doing in our practice as well. If we are seeing stage 2 and above, I think we are asking for MRI brain upfront. So that part, I think I agree with, sir. And it is probably, like you said, it was they knew that it's a win-win situation and they have gone ahead. So maybe there is something to think about over that.
So the third point which I would like to make is adjuvant chemotherapy was not given in 40%. Of course, I think they later on showed that even patients who have not received adjuvant chemotherapy or received adjuvant chemotherapy benefited. That is yes. But if you have seen the recent FDA comment, they did not grant permission to use a Chinese drug, a Chinese-made monoclonal antibody, a PD-1 inhibitor, in the US. They did not grant approval. One of the reasons they said was the trial did not have ethical values, because the control arm did not have chemotherapy at all. It was against placebo. So now 40% of these patients did not receive chemotherapy at all. So we already knew that chemotherapy, adjuvant chemotherapy, is an established treatment for these lung cancer patients. So in 40% of the patients who received only placebo, no osimertinib, no adjuvant chemotherapy, how ethical are we in comparing this thing? So because this thing was already known before the trial was out. So your comments on that, Sanyo?
Yeah. So regarding this comment regarding this 40%, I thought, that was okay. Why? Because stage 1B was almost 35%, 30 to 35%. So I feel majority of the patients who had not received chemo were in that 1B. I hope so, logically. Probably because in 1B, more than 4 centimeter, of course, there is a indication to give. Probably some clinician would have not given, because that criteria of giving chemotherapy versus not was dictated by the physician who is looking after the patient, not by the trial. So the 40% not receiving chemo, I suppose majority would have been 1B. That's okay, I suppose. But if at all, if you go into the details of this trial in the supplementary appendix and see how many of the 3A have not received chemo, then that would be a very interesting thing to know. How many of the 3A patients have not received chemo? So that's one thing.
Yeah.
The
I
other
think,
thing,
excellent point,
is
Sanjay.
regarding the CT MRI. That I don't think would have made a much difference, like what Vijit said. And the third thing is the DFS thing, what you said. That I thought I could not suddenly remember when you asked me. But then I was thinking this: how come? Even Deftinib, I mean, all those are also having only DFS. And after 2 years, if you say that there is no OS benefit, then what? We have been using it. So this point was there in my mind, and definitely that's a valid criticism. But then I probably, since this has got very good effect on the CNS, probably things may be different compared to the first or second generation TKI with this in this matter.
Yeah, I think excellent points, Sanya, because these were the criticisms of this trial, and I think you have taken it up point by point. Having seen
Sir,
all
can I
these
make a comment, sir?
Oh yes, Karthik, definitely.
Yeah. Sir, I think AstraZeneca people will be very unhappy because we are actually trying to criticize. The hazard ratio here is, I think, 0.17. So it is much better. I mean, far better than any of the TKs, first or second generation TKs, which was used and which actually gave a DFS benefit. And they did so much of, I think Rachan showed most of the slides, they did so much of what you call subset analysis, stage 1, whether osimertinib benefited or not in spite of giving chemotherapy. I think stage 1B there was less benefit, 2A and 2 and 3 there were more benefit of adding osimertinib with or without chemotherapy. So there was a clear-cut evidence telling that osimertinib did make a difference in those patients who did take chemotherapy as well as in those patients who did not take chemotherapy. So they tried to basically come out with the answer, and definitely I do agree if there would have been a subset where the osimertinib, if it had been compared with the standard chemotherapy maybe, and if all of them would have received chemotherapy, then I think yes, this would have been a fantastic trial. But there is a small loophole, but they tried to cover it with a lot of subset analysis, and they tried to tell that osimertinib did make difference with or without chemotherapy in all 3 stages.
Yeah, I think all of you have given very good answers to whatever criticism I had. I think that would make them very happy. So with that, I think I will end this session. We'll give the final
Sir,
thoughts.
one last question
Yes,
I
madam,
want to
that is
ask you, sir. Yeah, when we have done PET CT scan for staging, do we have to do MRI brain also for any stage? Usually we do staging PET CT, no, sir. So
definitely.
what about
So,
MRI brain?
Yeah, so I think I have the pleasure of deflecting that question to Dr. Sanya.
I will answer this. I mean, nice question. The immediate answer what you get from someone would be not required. MRI would not be required. But then if you see theoretically, PET is not a very good modality for brain imaging. Number one. Number two, I'll just give one very the practical example of what happened last week. One patient that was lymphoma, but this PET scan was showing a single lesion in the brain of around some 3 centimeters something. Okay. Then of course we did the radiation. I sent to radiation for RT, and then of course they wanted to do a MRI. They did a MRI. MRI showed multiple small lesions. Okay, so this is just an example of what I said. So I mean, of course, I think better. I mean, you have to do an MRI unless your treatment doesn't change.
Sir, if I can take this question, actually, I learned from my surgical oncology colleagues that whenever you are treating a patient of CA lung with a definitive, with that curative intent, you need to do a MRI. So whenever we refer the patient, even with stage 2, they did MRI, and it is perfectly right because the NCCN clearly tells that patient's MRI has to be done whenever you are going with a curative intent. So I think this has to be done in the patients with the early and resectable lung cancer.
Yeah, I think fair enough points here. Dr. Vijit, your final thoughts before I close this.
Sir, yeah, MRI stage 2 and above, sir, as per guidelines. The final thoughts, osimertinib, I think, yeah, like Dr. Karthik said, they'll be very unhappy if we don't talk about osimertinib in adjuvant setting in the second scenario. But I think by and large, most of my patients I'm not able to give this drug, sir. So unless AstraZeneca comes down on the cost, it's going to be difficult to give this in adjuvant setting.
Aparna, your final thoughts.
Yeah, I think we should explore osimertinib more and try to see the real world data for ourselves.
Yeah, fair enough. I think with that I will end. I think with the data available, my thoughts are that somebody with early stage lung cancer, he who's been operated, most of them, if they are EGFR positive, would get osimertinib. If it is not feasible due to financial reasons, I think we have two options. One is to give them chemotherapy alone. Other one is to give chemotherapy followed by gefitinib. Giving gefitinib alone might not be that optimal considering everything which is available. So with that, I would close this session and then go to the next one. So the next session is on advanced lung cancer, EGFR positive. So if I can call the faculty, Dr. Anant Pai, Dr. Namrata Udupa, Rachan, Guru, Hemant, and Najib. How many of them are there? Is everybody there? If you can just let me know who's not there.
I'm there, sir.
I am there, sir.
Okay. So let's, okay, Anant, I know you are there. Yes, Anant. So 54-year-old male, a former smoker, only for 20 years, diabetic, suffered pleuritic chest pain, breathlessness, and this is a lesion, left lower lobe lesion with adrenal metastasis. Histology is adenocarcinoma, stage 4. Namrata madam, what would you do for this patient next? CT chest, abdomen, stage 4 CL lung, adenocarcinoma.
Sir,
Two direct questions. One, whether you would do a PET CT for such a patient. Second, whether what is the mutation analysis you would do, and what type of platform would you use?
Sir, since the patient has already come to us with the CT thorax plus abdomen, I'll ask for an MRI brain only, sir. And I will ask for EGFR all-cross mutations. Because histopathology blocks are there with the patient, I will ask for these 3 mutations, sir.
Excellent. Anant, any different thoughts once they reach Manipal?
Sir, I think adding bone scan would be a good thought process, because sometimes we have seen that they may have particular meds. If symptomatic, definitely yes, but otherwise also we are moved totally towards PET CT now for evaluation of a lung mass, because most of them come with the X-ray or a plain CT showing a lung mass. But if CT
So if this patient had come to you?
Bone scan probably, sir. Add a bone scan and MRI brain. And then EGFR, the routine mutation analysis on the blocks.
Rachan, what about you? Same question. You also have a PET machine. What would you do?
CT thorax abdomen done, probably MRI brain and bone scan. But if a very well-to-do patient, he will tell PET and PET is comparable, so PET and baseline. If finances are an issue with most of our patients, then only MRI brain and bone scan.
What about mutation testing? What would you do?
Yeah, I'll send the lung NGS. I would rather send all EGFR, all cross met, KRAS.
Would you do a hotspot NGS or a CGP?
I don't know. Frankly, I don't know.
Guru, what would you do if you are there? Hemant, what about you?
Imaging, the least I would add is a bone scan. Many times in practice, I've not done MRI. But yes, preferable to do a PET. Most often I send EGFR all cross based on PCR and IHC. Tend to add PDL1 wherever feasible, but preferably would like to do an NGS. Hotspot most so. Okay. Reason because slightly earlier reporting, that's it, nothing.
Fair enough. So this patient came as adenocarcinoma, EGFR positive, L858R. So what is your choice, Najib? If Najib is not there, Anant?
At this point of time, most of us are still giving Jeftinib, sir. But if affordable, probably Osimertinib.
So, Namrata, this patient has come to you, L858R. Basically, the son and daughter is in US and Australia. What would you do?
Sir, because they are affordable. You mean they are affordable? We'll prescribe Osimertinib. Otherwise, practically, I'm giving that sort of patient Jeftinib or Erlotinib in the first line.
Rachan, same patient with son and daughter in Australia and US, but they are working in grocery shop as helpers. What would you do?
Jeftinib and Erlotinib. Jeftinib.
Okay. Hemant, when would you consider a combination of chemotherapy plus TKI?
Moreover, I'm switching to, at least in our setting, wherever feasible, combination of Jeftinib plus chemotherapy. Rather than Jeftinib alone, in case only if its patient is elderly and not probably fit for chemotherapy. The toxicities are fairly well manageable. It's not that difficult as what was expected. But if given a choice of Jeftinib plus chemotherapy versus Osimertinib, a single tablet, I would prefer Osimertinib.
Okay. Organizers, if Dr. Najib or Guru Prasad comes into the picture, please let me know. Next, Anant, when would you ever use Erlotinib and Bevacizumab? Anant?
Hello?
Would you ever use Erlotinib Bevacizumab? If yes, which patient?
I haven't used it yet upfront, sir. Adding Bevacizumab, usually I, like I said, I stick to the TKI only. So I've incorporated Bev with chemotherapy, but not with TKIs.
Fair enough. Fair enough. Would we know that the NCCN guidelines?
So can't hear you, sir.
Okay, can you hear me now?
Yes, better.
Sorry. So we all know that Osimertinib is now the preferred agent. Is it because of efficacy, safety, quality of life, or overall survival data? Namrata, which one of these is the one reason you would select Osimertinib?
Efficacy, sir.
Efficacy, isn't it? So in terms of efficacy, this is, I think, DFS is 18.9 months. And I think the Ramucirumab plus Erlotinib data is 19.4 months. Does that make you think about Ramucirumab plus Erlotinib, Namrata?
Ramucirumab plus Erlotinib I haven't used so far, sir. But
that is the one with the maximum DFS, isn't it? 19.6.
Yes, sir. But I think the toxicity wise, Osimertinib is better than this combination.
Fair enough. Fair enough. So in terms of PFS, Osimertinib had an excellent data in terms of PFS of 18.9 months. So depending on the type of mutation, Rachan. So this patient had L858R. Does it bother you, or you treat them the same way as Del19?
Exon L858R, they do slightly less better than exon 19 mutations. But yeah, I would still use Jeftinib only, because second line, this one Dacometinib, Afatinib is much more toxic. Osimertinib is...
yeah. Sorry. Osimertinib is less toxic. So if affordable, you would prefer Osimertinib, isn't it?
Yes.
And Hemant, there are some, data, especially from the Archer trial, which suggests that Dacometinib is a slightly better drug for L858R. What do you think? Is it true?
Yeah, probably yes. Exon 19 deletion tend to do actually much better. In practice, also you have seen that exon 19 deletion. But again, we are trying to dissect the subset analysis. In case somebody is not affordable for Osimertinib, my current choice would be trying to kind of push for Afatinib at least, because we have that. Archer toxicity, Dacometinib is significant, diarrhea is significant. Would not be my preferred choice still.
Fair enough. So toxicity, we all know. We also know that if you look at the overall response rate, it's quite high. maximum with osimertinib with 80%, as well as the duration of response is around 18 months. So overall survival data, we know that Flora showed an excellent overall survival data, 38 months versus 32 months. And Archer overall survival data. Anant, your thoughts on the Archer overall survival data? 27 versus 34 months. It was published in Lancet, saying that there is significant benefit.
Yes, sir. So basically, yes, numerically it is definitely there. Quite a good improvement in the overall survival, sir. But the thing is, I think so. Like we all know, toxicity has also an effect. So dacometinib numerically definitely showed a better overall survival benefit, sir.
Rachan, you are the statistician. What did you think about the fact that the Archer study later on they said there is overall survival benefit, but according to the design of hierarchical assessment, only if patient had overall response rate benefit, we should have done the overall survival. What is your thought process on that?
I think I'm not the statistician.
That's what I said, sir.
Okay.
Numerically, it looks better.
Okay. Fine, because you know what has happened is actually it shows overall survival benefit, but they are designed in such a way that they had to first check whether there was PFS benefit, which it did. Then it had shown overall response rate benefit, which it didn't. And even though there was a survival benefit, you just cannot proceed and claim that there is overall survival benefit. And that's what happened when the Canadian authorities rejected it. So while choosing EGFR, would you ever think the risk of developing CNS mets and hence decide your treatment, madam? And this question for you. Do you routinely do MRI brain?
Stage 4, yes, sir. I do routinely MRI.
And how concerned are you when you pick up the prescription to write about brain metastasis?
Sir, osimertinib is better if the patient is affordable. Else, among the other two drugs, I would prefer erlotinib as compared to geftinib.
So you would not consider dacometinib at all, would you?
Dacometinib still have no experience.
Fair enough. Hemant, what about you? Your thoughts on this? Which drug would you use? Would you use osimertinib because it has brain penetration capacity?
Yes, I think yeah, ideally to do brain MRI. No, in my practice, I do not do brain MRI for all patients. Preferred choice would be osimertinib, and in case I do pick up a small metastasis and patient is asymptomatic, I'll let alone be that and proceed with osimertinib feasible.
Fair enough. This is just to say that the Lux Lung 7 trial, subtle brain mets were included, but afatinib did not show overall survival benefit. Archer, all brain mets were excluded, but there are case reports of dacometinib working in the brain. Flora, of course, the stable brain mets were included and it showed good response. CNS response was clearly seen with osimertinib. In terms of PDL1 positivity, what is your thoughts, Hemant? You just mentioned something the other day. Good to share that.
Yes. So I first discussed the patient. So this was a non-smoker, 46-year-old metastatic CA lung. He had large neck nodal mass with CA lung. EGFR all-cross by EGFR by PCR and all-cross by IHC negative. PDL1 95%, and discussed in the group in case any role of, I think, low-dose immunotherapy, everything I had discussed. Then I discussed with one Dr. Nirmal Roth, who's in Mumbai and who has clinical trials for lung cancer and his area of focus lung cancer. He's told me that when somebody has got a really high PDL1, they have a tendency to have a driver mutation, and many times we end up failing in these patients rather than somebody having PDL1 positive of probably 50%, 45%, or probably 60%. When somebody who's got a PDL1 of 95%, better to kind of confirm that there is no driver mutation and then only proceed with IO. So that was about that case. In case of patient who's got PDL1 along with the EGFR positive, definitely I will not consider in those subset. though we have got data for IN power 150. And second thing, what Karthik sir had presented that was very impressive, that somebody who had a PDL1 negative and EGFR positive tend to do really well. That data I did not know, and probably I'll start focusing that way as well.
Yeah, so we all know that immunotherapy does not do that good a job in patients who are EGFR positive. Anant, your thoughts? Imagine a patient has got a PDL1 99%, and you have done everything. EGFR all cross is negative. You start the patient on on immunotherapy plus chemotherapy, and at the second cycle, this patient's relatives ask for NGS and you get it done. EGFR is now positive. What would you do next? Anant, are you there? Anant? Madam Namrata, you take that question.
Sorry, sir, I did not get your question, sir.
Okay, so this is a man who has got PDL1 95%, EGFR all cross negative by our usual, RT-PCR and IHC, and you have started on chemoimmunotherapy. Relatives obviously are in US, that's why you were able to start chemoimmunotherapy. But after 2 cycles and third cycle, somebody there wants an NGS done, and NGS shows EGFR 95%. You have finished 3 cycles of PEM, Carbo, and Keytruda. What would you do next?
Interim reassessment, sir. Post 3 cycles.
Shows good response. What would you do next?
Then we'll continue with the same, sir.
If you complete 6 cycles, after that, what would you do?
Then I'll reassess him again. If the response is good, we can continue it still, sir.
And you would continue immunotherapy, and on progression, you would change to a TKI.
Yes, sir. Yes, sir. We'll keep it as reserve.
Fair enough. Fair enough. Rachan, what would you do, and any precaution of TKI?
In a patient who chemo is already started, the guidelines suggested to complete chemo and give maintenance this targeted therapy. In this patient, since immunotherapy is most patients who have targeted mutation, driver mutation, they don't respond well to immunotherapy. So this response which we are seeing is probably due to chemotherapy. So complete chemotherapy and followed by targeted therapy. That would be my choice based on
any precautions or any worrying thing you have seen when you give targeted therapy after immunotherapy?
Initial lung disease. Yeah, that's I've seen some patients who have received some palliative RT also developing ILDs in that field.
Yeah, especially I think with osimertinib, there are case reports of severe pneumonitis. If you have used immuno-oncology drug before, you're supposed to wait for 3 months before you restart or you start patients on TKIs. Regarding safety, we all know this is an extremely safe drug. Quality of life is good. So when would you consider a sequencing approach, Anant? Anant, are you there?
Sir, yeah, I think there's some network problem, sir. Can you hear me now, sir? Hello, sir?
Yeah, I can hear you. When would you consider sequencing treatment?
Yeah, like we know that in some patients, we can at least start with hepatinib like L858R in case osimertinib is.
Definite network issues. Namrata, what about you? In which patients do you think about sequencing?
First line osimertinib is better in any patient with EGFR mutation, sir. Upfront to start with, if finance is not an issue.
Excellent.
So after that, on progression, we'll rebiopsy the patient and look for mutations. If they are not, then we will shift the patient if he is having good performance status still to chemotherapy.
Excellent. So you are very, very clear that there is nothing like sequencing. The first thing you would always use the best drug, osimertinib, upfront, right?
Yes, sir.
Excellent.
Because,
Rachan, your thoughts? Sorry, Namrata, go ahead.
14% issue, then we will go for the first generation ones.
Fair enough. Rachan, your thoughts? Why would you want to give always osimertinib? You can use the geotag study. I think I'll just put this, the geotag study, which was a retrospective analysis and showed a very good response if you give first second generation TKI and then give osimertinib at progression. What are your thoughts on the geotag?
The problem is it's not always, it's not possible to catch them when they progress. So if they progress, they may not be able to receive subsequent treatment. So catching them frequent follow-ups is very difficult. So I believe in using the best drug upfront rather than using.
Hemant, your thoughts on the geotag?
Yeah, the exclusion criteria, you see that patients who died on first-line afatinib excluded, who could not receive second-line therapy excluded. That ends up being a major chunk at times. And definitely with the burden of disease that we see our patients present, on progression, they tend to do really bad. So in case I have an option, definitely first-line, a single agent, best option will be first.
Excellent. I think here you can see that if you take 10 patients, just like how you have told, 3 of them will die and will not receive second line therapy. Out of the remaining 6, another 3 you cannot catch them, like how Rachan said. You cannot do a tissue biopsy. It's difficult to do. So you may not end up giving osimertinib in nearly 70% of these patients. So I think that's excellent. I think now everybody is happy. All 4 panelists are very clear that osimertinib would be their choice, first choice for patients with metastatic EGFR positive lung cancer, whether it is L858R or whether it is DEL19. So, yes.
Sorry,
yes.
for just
yes,
I want.
Rachan.
What about using dual TKIs, osimertinib plus second generation? Is there any studies like that?
Yeah, I think there were studies. I think there were increased deaths, if I'm sure. Hemant, do you remember anything? Combination?
No, I can't remember the I do remember that there has been study, but I don't remember the data. There has been some evidence for using osimertinib and MET inhibitors as a continued therapy. There have been studies of using afatinib with cetuximab for patients to get better response, but they had very high incidence of skin rash and toxicity. But I don't remember specifically 2 TKs. I can't remember the study.
I am not able to remember exactly, but I think there is a study where they showed increased deaths. So, but very interesting question, Rachan. So, Rachan, you get the points. What do you want to say about first line TKI in metastatic EGFR positive lung cancer?
A regular mutation, I would use osimertinib. Uncommon mutations, think about using second line second generation ones. So all patients who can afford osimertinib has to be on innovator osimertinib.
Excellent, excellent closing comments. Anant, your final thoughts?
Sir, like I said, the first line for all patients who can afford osimertinib. Otherwise, routine practice, it's usually has been jeptinib. But I think with the prices coming down, maybe we'll be able to push some more osimertinib.
Excellent. Madam, your final thoughts?
Sir, I agree with others. First line, we have to use the osimertinib. The monthly cost, I think they were quoting 1.2 lakhs today. So still it may not be within the reach of the kind of patients we deal with. If they bring the price further down, first line of choice practical choice would be osimertinib. Otherwise, we have to continue with jeptinib or erlotinib.
Fair enough. Hemant, your final comments?
Yeah, I agree with everyone. Affordability still becomes a major issue despite the cost reduction. But otherwise, it's an excellent drug in the sense that you have a single drug, oral therapy, single dosing, very good toxicity profile, manageable, and patients tend to do well who are on that. We've seen that. So the drug is excellent. Only this is one drawback, and probably they'll do much better that way. One interesting thing which I was probably going through, that patients also tend to have some leptomeningeal disease, leptomeningeal metastasis, and there is some study for double dosing, 160 mg, a Bloom study or something, which had a better response rates in that. So other than that, I think we end up using the same 80 mg.
So I'll end this session by saying osimertinib is the drug of choice because of 3 reasons. One, the efficacy is very good. Second, tolerability is excellent. And third, CNS penetration in a disease where incidence of CNS mets is high. With that, I hand it over back to the organizers. One last comment is Sanyu had an interesting point to make about one of his patients. If he can do that and then hand it over to Anand for his closing comments.
Yeah. So this is regarding the hematologic toxicity of osimertinib. So I was talking about that adjuvant patient. I mean, after pemetrexed and cisplatin, I suppose. I started on adjuvant osimertinib. So after, I mean, 80 mg dose, after 1.5 to 2 months, he started developing thrombocytopenia and neutropenia. And the platelets went down till 54,000 and WBC of around 2,300 and neutrophils of around 50% around. It will be like grade 2 neutropenia. So grade 2 neutropenia and grade 2 thrombocytopenia, platelets of around 54,000. But then that didn't recover for almost 1.5 month, 1.5 2 months. Because initially I was giving 80 milligram. Then once I got to know that the platelets and neutrophils are, I mean, WBC is coming down. So then I started on, I think, alternate days for, I think, 2 weeks. Then with this alternate day 2 weeks also, the WBC and platelets went down. And then both the relatives and myself were quite apprehensive in continuing the treatment. And then stopped it for almost 2.5 months. And now last week I started with the 40 mg alternate day. Let's see what happens after 2 weeks. Now after waiting for 2.5 months, the platelets came up till 99,000 and WBC came up till 4,000. So has anyone seen such myelosuppression with osimertinib, or is it probably because of post chemo? But then if you see the post chemo, the trial ADORA, in that there was not mention of this side effect, because this was probably less than 10%.
Yeah, if I can take that, I have not seen anybody with pancytopenia, and I never knew that 40 milligram osimertinib is available.
No, only you can score it. It was not available. You have to score it.
Okay, Sanya. Okay, bye.
I did the vitamin B12, folic acid, all those things. Of course, those were a little on the lower side, but they were not quite low. He was could not find out why it happened in that patient.